Jason, and thank you everyone for hosting me. But I'm very fortunate to be here with you today. Just some appreciation and disclosures. I think what I'd like to point out is that, South Africa used to be a leader in rugby. And then when I was trying to look, we are still above Australia in the sevens rugby. So let's just focus on that for the moment. So today I'm just going to look at the challenges in infectious diseases that we are facing in South Africa, the South African healthcare landscape, and then a paper that we've written on how to quantify antimicrobial usage, because we've heard some great talks today on resistance and how antibiotics work, but I think it's always good to also know how much antibiotics you're using, what's the quantity, because otherwise if you don't know where you're coming from, you don't really know where you're going to, and then some future directions in stewardship. This is South Africa, so this is a country apart from Africa, and I'm from Pretoria. This is Johannesburg, where everyone's scared to travel from, but I've met a lot of South Africans today that comes from Johannesburg, and people normally think if you go to Johannesburg, you're going to get mugged and killed, which might happen, but I've driven with, I can't deny that fact, but I've driven with Jason late at night in Johannesburg, and yet we are still here. We even got lost. So this is where everyone wants to go, but we don't have water there at the moment, except the sea, so just wait a little bit. Okay, so in South Africa, we have a unique landscape, and we've got, it's such a country of stark realities, and this is our realities as well. We have HIV, we have lots of multi-drug resistant TB, so if you really need, if you need to get away from the gram-negatives and gram-positives, comes to South Africa. We've got beautiful landscapes and beautiful bugs, okay? So this is a paper that we published on fluoroquinolone-resistant Salmonella Typhi. It's a paper that was published just in December, where we had a typhoid outbreak how lucky am I, just in the time that we had our Ohio residents. We have an exchange agreement with Ohio State. So, so we had these 2 Salmonella typhoid patients in the wake of typhoid, and we described this actually quite well if you want to have a look at it. But what this paper actually did is it actually showed how, I work in the second largest hospital in Africa, very rural-based. A lot of the times, our taps aren't working. But what this showed is that our Salmonella typhoid, we could actually help. Okay, the one patient died, but it wasn't because of anything we did. It's just the other patient came out relatively well, but how our collaborative efforts, the pharmacist, the doctor, we even had an epidemiologist, how we all worked together to resolve the case, and we describe it actually quite nicely in this paper. So I just wanted to show you that antibiotic resistance is a global public health emergency, not just for South Africa, but this is actually, I wanted to take some pediatric figures, so this is just for you. And this is infant mortality based on nothing else but antibiotic resistance. It comes from the WHO website. So you can see in Africa, because of antibiotic resistance, 158,000 babies died last year. In Thailand, 38,000, United States, 23,000, Europe, 25, and then in the States of India, 58,000 babies. I don't have you on this slide. I don't think it's, I just couldn't find any data. And then in the South African health scape, I just wanted to explain actually to you the majority of South Africans still rely on the public healthcare system, which is actually makes up about 82.5% of the country, and then about 17.5% relies on the public healthcare sector, which I'm going to show some pictures in tonight's talk. But if you look at the expenditure, there's still a lot of inequities, and we are also in the world known as the country with the largest variances in GDP. So in other words, there's lots of inequality still in South Africa. So the annual expenditure in the public healthcare sector is 122.4 billion, and in the private sector, 120.8 billion in healthcare. So you can see 82.5 versus 17.5. And that's our challenge, really. We still have to look at all of those people. This is where I work. Very rural, and we still have, on Saturday's talk, I'm going to show you the WHO E profile for South Africa versus the E profile for Australia. we have a lot less physicians per patient than what other countries has. And that's a challenge for everyone, including the pharmacists. These are some quotes that comes from our government sector, and I'm not going to read all of it, but it just shows you the reality of living with and without a medical aid in South Africa. And I'll maybe just read one, the emergency support. My medical aid does cover emergency ambulance pickups, but unfortunately I find that I still have to pay extra from my pocket. And then public healthcare sector, I can't afford to call a private ambulance, so my option is using public ambulance. They're overburdened, so life becomes difficult when you're faced with an emergency. So that's the realities that we have. Doctor availabilities, long waiting lines. So the hospital standards are different. If you come to our private hospitals, you'll see world class. Whereas public healthcare with NHI, we're moving towards the national health insurance, which might resonate with what you have in Australia and even in the UK and in other countries. So we're moving towards that, and we are in phase 2 of implementing the national health insurance. It's a completely different talk for another day, but our challenges there are that we don't have enough taxpayers to actually pay for the national health insurance, and South Africa's borders are open. So that means in a rural clinic where I did my community service, I don't know if you guys have community service, but I was placed in a very rural clinic in the middle of Mamelodi, and I saw 100 HIV patients a day, and 20% of those 100 patients that I saw a day came from not from South Africa. So they would constantly be complaining to me about not making my budget. But then I said, I actually did make my budget for the 20% of the people that I saw. So we are carrying a lot of other people. In terms of stewardship, it makes it a challenge because we have to use the resources that we have. But we're getting the immigrants, we're getting a lot of disease states like Salmonella Typhi, where our 2 patients, the one was from Mozambique and the other one was from Zimbabwe. So it makes it difficult in terms of your etiology and your resources. My cousin is actually what would you call it? Do you call them lawyers? Or in the UK, where's our UK person? Yeah, there he is. You call them, what do you call them again? Okay, money. Oh, I'm just going to phone him up right after this. So my cousin is a Moneygrabbing in Perth, and he actually came to South Africa to study our constitution, and our constitution is actually spoke about it in 1994 in terms of transformation for healthcare, and that's what we are working towards. We also have our essential medicine lists. That's all based on application. So our guidelines for using antibiotics is very, very clear. If you want to know what to use for UTI, you go onto your phone and you know exactly what to use. It's easily accessible, so if it's not on the EML, you cannot access it. So you can't get that antibiotic. But in the private sector, if you are a doctor, you are king. You can just prescribe anything that you want. Okay, so that's the challenge. So this is the policy context that I've explained: public versus private, HIV and communicable diseases. So this is Maslow. We have Maslow's sociology hierarchy of needs. I hope everyone understands my accent. I'm just realizing as I'm talking. But it might be a little different. So I just wanted to give you this hierarchy of antimicrobial stewardship in South Africa. So the majority of the time, the first thing that I do when I visit our public hospitals is I have a look at whether or not there's soap. There's soap at the tap. Because if there's no soap, it means no one is washing their hands. Then really, you can throw meropenem, you can throw fluoroquinolones in that unit, but it's not going to change a thing if no one's washing their hands. So that's the first thing. And I normally ask to the stock controller, so do you know which wards doesn't often, order soap? Because those are the wards that you should be focusing on, okay? And then drug utilization is what I'm going to look at as well. Education, implementation, and frameworks. We have to feed back. It all seems very simple, but can get a little tough. South Africa has got isolated areas, in our country where it's working really well. So if I had to come here today and I came from Netcare, I'd show you a picture that's so beautiful you'd want to come and work in Netcare and just cry. But, so there's pockets of greatness. Like I've heard Jason's, research group, that's, and everyone else that's doing fantastic things here. So that's the same in South Africa, but we want to bridge the gap and really make it uniform to try and address the needs. So what's happened in South Africa, we've had major policy shifts over the last 6 years. So since 2012, we started the South African Antibiotic Stewardship Program. And it's a ministerial appointed committee. So it comes from the Minister of Health. He's very strong in terms of supporting this group. And that's really made a big change because South Africa now has this antimicrobial resistance strategy framework published in 2014, and we've got deliverables so the minister is expecting these deliverables to happen by 2019, which is next year. So it places a lot of pressure on everyone involved. But this group includes veterinarians, that's hence my question. It includes epidemiologists, pharmacists, nurses. Everybody has to get on board. And we are rating our public sector hospitals now based on your antibiotic. So in other words, how well are you using your antibiotics? What resistance patterns are we seeing? And the veterinarians now of the local area has to report on what type of outbreaks they've seen, because we've seen MCR1, Colistin resistance that comes from poultry. And then we'll see outbreaks. We've seen, for example, phosphomycin resistance, typhoid in poultry. We saw salmonella outbreaks in the neighbouring hospital. So that's why we're really taking a firm stance on One Health approach as part of stewardship. So our veterinarians work closely. Last week I had to speak at the equine conference in Cape Town. So I had to speak to horse farmers, and the week before that I spoke to the red meat farmers, and the farmers, they call you Poppy, so it doesn't matter what I do. Poppy is Afrikaans for, it means like little girl. So, you first have to tell them. So when they ask you a question, they'll say, so little girl, what do I do if there's a cold front coming? Can I just give all of my horses antibiotics? And I'm saying, no, really, I understand your horses are expensive, but antibiotics is expensive as well. So this is actually quite well. We've just written a paper that I'm very happy to say is going to be published in the Lancet Infectious Diseases next week. Hooray, it's like winning the lotto. I've done it with all of my colleagues there. Actually, they've done it, and I've just added to it. But with Colistin, the veterinarians have said that you can no longer use Colistin as part of fattening up animals, to put it, because that's what was happening in our industry, pigs and so on. So they've placed this ban on using Colistin as part of animal use, and this comes from our framework. And what I want to focus on is enhancing surveillance. So we also included vaccination as part of the scope of practice of pharmacists for preventative care. And these are the deliverables by the National Antimicrobial Support or Stewardship Program that has to be delivered by 2019. And you'll see vaccination, and there's enablers. So for every objective, there's an enabler as to what we have to achieve. And this is what I've said. The one thing that we are still struggling with is looking at agriculture, forestry and fishery. I want to be the one that does that, but no one wants to let me go into the rivers and take samples, etc. So I'm very open to do that for this team. But everyone else is on board. And the Global Action Plan also asks, the WHO is asking for surveillance data every 5 years from every country. So if I had to ask anyone in the office or in this audience at the moment, do you know, can you tell me the defined daily dose of your meropenem or carbapenem consumption for the last year? Will you be able to say yes? I know it's Australia, so you probably will say yes. Wish I was in another country right now. It would just make it so much better. Okay, but anyway, so I've just said this, and I just want to show you this, that about 7 million people in South Africa is on antiretrovirals. 7 million people, it's larger than the population in Scotland. Scotland has 5 million people. South Africa has 7 million people on antiretrovirals, so it's a big program. So to that effect, we've written this paper that was published last year. It was a situational analysis of current governance, regulation, utilization. So we didn't have the figures that you just said yes to because our public sector is paper-based. So it means that we can't get data. I can't tell you. In the largest hospital in Africa, which is where Professor Jeff Lipman comes from, I can't tell you how much antibiotics they've used. So we might have resistance figures, but I can't tell you what they used, and that's not a good way to go forward. So what we did is we wanted to get that data, and we wanted to get it in conjunction. We wanted to analyze it. So what we said is we don't only want antibiotic data, because our country has got the largest program of antiretroviral, we want antiretroviral data and we want TB data as well, which was not a small task. So what did we do? We got IMS data for the private sector, no problem, but they're only 12%. I mean, so it's like they don't count, okay? So then we wanted to get the public sector data. So what we did is we used procurement data, and what we did is we used a marketing terminology. So we used some marketing terminology and we quantified antibiotic use in quantities per ATC class so that we could give it to the WHO. And then we used moving annual total units because we knew if we spoke money, the politicians will listen. So then that's exactly what we did. We used this. This is a comparable metric of antimicrobial consumption. This is what marketing people use. And we used our tender data and we plugged it into this formula and we could spit out all of these beautiful tables to them and tell them if antibiotic use has increased or decreased for the country of South Africa. And in the private sector, it's decreased by 2%. But what you'll see is broad-spectrum penicillins are still used there, injectable and oral. But our other include daptomycin, fusidic acid, linezolid, where's our gram-positive man from the UK, there you go, and tigecycline. And then, but in the public sector, unfortunately, antibiotic use has increased by 11%. Okay, so what is happening there? Broad-spectrum oral penicillin still, trimethoprim combinations. This is important for us. You guys use it for UTIs, I've heard earlier, but we use it as prevention therapy for HIV, for the patients that are immune compromised, and that makes it completely different. We can't just use other people's guidelines and plug and play in South Africa because Bactrim is most probably resistant, and our healthcare professionals don't really stop it after 6 weeks. So they just continue. And what we're also seeing there is narrow spectrum penicillins, 22%. But look at that. 6,876% was the growth in all other antibacterials. The main drug there, linezolid, but not for gram-positive infections, no TB, multi-drug resistant TB. It tells us that we're not as great in managing TB as we thought we had. And then antiretrovirals, our problem there is not the fixed dose combination, it's all other antivirals. Our nurses have initiated antiretroviral therapy in our public sector, and unfortunately, we're really good at rolling it out, but we're not very good at monitoring it. So we're starting to see resistance. This is dolutegravir that we're importing from other countries. And TB was hydrozides and thiocarbamides, which is used for prevention therapy. So future directions, the South African response. This is a colleague of mine, Mark Mendelson, that wrote Wake Up South Africa, the Antibiotic Horse Has Bolted. Great read. And what we've done is they've done a large non-specialized pharmacist-led study in our limited patient hospitals that you can access. They've published this framework. It was signed by all of the stakeholders, all of the ministers, so to pledge to work on antibiotic stewardship. All of these people came on board. We work with the Global Antibiotic Resistance Partnership, which is in every country throughout the world. We're busy with phase 2. And the South African Society of Clinical Pharmacy, which Jason came out twice for, is publishing a lot of guidelines, including Colistin guidelines, which we are also updating. We also have an African utilization research group because we are part of Africa, even though people think we are Africa, but we are part of Africa. But where we work, actually I work in Kenya, and then fortunately enough in Mauritius. It's fantastic, I love going there. But then we look at resistance in those countries because we realize, so we work with our other regions as well. This is our paper that's going to be published next month, a position paper on the pharmacist role in antibiotic stewardship, where we have identified different role players. So the infectious diseases specialist and what everybody's role is. We did a study across our pharmacy schools, and we've also done it the same in our medicine schools. We're busy with a veterinarian school one to find out baseline what our students know across the 9 universities, because it's not standardized in terms of exactly, academics don't like to be prescribed, you have to teach this, they don't like that. So we went to the students to try and find out what they knew. It was okay, but the discrepancies between the unis were too big, so we realized that we had to intervene, which we did. We have mobile applications that you can access anywhere. You guys can also download our EMLs. So I think, in terms of future views and conclusions, to get consumption data still remains a challenge, but I think it's important because it shows what your country's problems are. For example, we know that we've got challenges in terms of HIV and TB. Our antibiotic resistance is also a problem, but it's not our biggest problem. And there are other indicators that you could use. I think South Africa and probably Australia is well placed to contribute to the knowledge base of antimicrobial use. And I always think about this. It's good to be individually brilliant and to have a strong core competencies, but unless you're able to do the work in a team and harness each other's core competencies, you'll always perform below par because there will always be a situation at which you'll do poorly and someone else does work. And antibiotic stewardship is mainly about situational leadership, letting the person with a relevant core competency for the situation takes leadership. For example, your beautiful presentation that you had on allergies, on fungal stewardship, gram-positive, gram-negative, there will always be someone that has that speciality. And in South Africa, we've seen that works with that committee. Everybody takes leadership. It doesn't necessarily have to be the physician. Sometimes it's the pharmacist, sometimes it's the nurse. And that's it. Thank you.